Welcome back to the deep dive. This is where we take those really dense clinical guidelines, the protocols, all those numbers you need for exams, and we try to turn them into something you can actually recall instantly.
Yeah, exactly. And today, it's really a knowledge consolidation mission. We're thinking specifically about you, the learner. Maybe you're facing the AKT or similar high-stakes exams.
Right.
We know it's tough, right? Trying to remember the exact TSH cutoff or how long precisely you can use that potent steroid or the specific ACD steps for hypertension.
Oh, absolutely.
So our aim today is to hammer down those non-negotiable numerical facts, the definitive timeframes, the absolute protocols. These are the things that underpin safe practice, obviously, but also, let's be honest, high scores in these exams.
Exactly. And we're not just, reading out lists. We want to give the why behind the number, make it stickier. We pulled sources covering those areas that are, well, often just pure rote memory, but where knowing the context makes all the difference.
Definitely. We're going to cover sort of 4 main areas that are really core for GP trainees. First, those regulatory standards, think DVLA, flying rules, benefits paperwork, all that admin stuff.
The essentials.
Then, evidence and statistics, the basics you need to interpret papers. Third, high-stakes pediatrics, everything from milestones to acute stuff.
Okay.
And finally, those stepwise management protocols will hit dermatology and cardiology pretty hard.
Okay, let's unpack this then, starting with the rules.
Right.
The ones that define who gets to drive, who can fly, and why getting these regulatory standards right is often, the first really urgent thing we face.
Okay, so the absolute foundation here, and it's a legal thing, is that every single driver has to meet the DVLA medical standards for their license group.
Group 1 or Group 2.
Right. And the crucial bit for us, clinically, is advising the patient they must tell the DVLA if they develop any condition that could affect safe driving. That's our duty.
And it makes sense that the rules depend on the group. Group 1 is cars, motorbikes. Group 2 is lorries, buses. Much higher risk, so stricter rules.
Exactly. Group 2 standards are always tougher because, well, the potential consequences of an incapacitating event are just so much greater.
So let's start with vision. Group 1, what are the hard numbers?
Okay, Group 1 vision standards, non-negotiable. Acuity has to be at least 612.
612.
That's with both eyes tested together, or in the one remaining eye if they're monocular. And that's with glasses or contacts if they need them.
Okay. And the number plate test.
Yes, the practical bit. They also have to be able to read a standard number plate at the statutory distance, which is 20 meters.
20 meters, got it. Visual fields are more complex, though.
They are, and very precise. For Group 1, the binocular horizontal field needs to be at least 120 degrees.
120 degrees.
And within that, you need at least 50 degrees to the left and 50 degrees to the right. Critically, no significant defect within the central 20 degrees of fixation.
Central 20 degrees. Important.
Very. And if someone has something affecting both fields, like a homonymous hemianopia or maybe advanced bilateral retinopathy, they're very likely to fail, especially for Group 2, which needs a much wider, clear field.
Okay, moving on to diabetes. The definition of severe hypoglycemia is key here for knowing when to notify.
Absolutely key. For DVLA purposes, severe hypo means needing help from another person to treat it. That's the trigger.
Needs help from someone else. Right.
That definition immediately dictates the notification rules. So if a severe hypo happens while driving, both Group 1 and Group 2 drivers have to stop immediately and notify the DVLA, no question.
What about hypos when not driving? Does it differ for Group 1 and 2?
It does. For Group 1, if control is generally good, they might be okay. But if they have more than one severe hypo while awake within a 12-month period...
More than 1 in 12 months while awake.
Then they must stop driving and notify the DVLA.
And Group 2, I suspect it's much stricter.
Oh, far stricter. For Group 2, any severe hypo in the last 12 months means stop driving and notify immediately.
Any single one?
Any single one. Or if they have impaired awareness of hypoglycemia. Getting their license back is a long, complex process. It needs specialist input, continuous glucose monitoring data. It reflects that huge public safety responsibility with commercial driving.
Makes sense. Okay, epilepsy and seizures. This feels like one of the most immediate things we deal with. The rule seems clear-cut.
It is. After any epileptic seizure, the advice is unequivocal. Stop driving immediately. Notify the DVLA.
Stop and notify, always. What about getting back behind the wheel? The time frames.
For established epilepsy, the typical rule for Group 1 is 12 months seizure-free.
12 months.
There are some nuances, things like sleep-only seizures might have slightly different rules, but 12 months is the default safety window. If it was a provoked seizure, maybe shorter, but notification is still mandatory.
And Group 2, again, much longer.
Extremely long, typically 10 years seizure-free and off all anti-epilepsy medication before they can even be considered for relicensing, and again, requires specialist reports.
Wow, 10 years. That 12-month rule for Group 1, is that based on risk dropping off?
Precisely. The data shows the risk of another seizure falls significantly after that first year seizure-free. It's an administrative rule, really, based on minimizing that peak risk period. We see a similar risk-based logic with things like stroke and TIA.
Right, so let's get those time limits. Stroke TIA. Critical numbers.
Okay. For Group 1, after a stroke or a TIA, they must stop driving for at least 1 month, minimum.
1 month.
They can potentially resume after that month if there are no residual neurological or cognitive problems affecting driving. But, and this is key, they still must notify the DVLA.
Why 1 month specifically?
It's based on that peak risk window again. The highest chance of having another stroke or TIA is within those first 30 days.
Okay. And Group 2 after stroke TIA?
Stop driving, notify the DVLA, and usually looking at a minimum of 12 months off driving before they can even apply for relicensing consideration. Allows for full recovery assessment, cause finding, treatment optimization.
Right. Now, cardiac events, MIs, procedures. You mentioned the difference between medical management and procedures is important.
Yeah, let's get really specific on these Group 1 cardiac times. Uncomplicated MI, managed medically, no procedures.
Just tablets.
Right, that's 4 weeks off driving, minimum. Gives the heart muscle time to heal, stabilize electrically.
4 weeks for medical MI.
Yeah.
What about elective PCI? Stent put in, planned procedure.
If it's an elective PCI and it's uncomplicated,
Okay.
the time off drops right down to just 1 week.
1 week. That seems incredibly quick after heart plumbing.
It does, doesn't it? But the logic is about distinguishing muscle damage from just sort of mechanical stabilization. An uncomplicated elective PCI means the artery's open, the immediate risk of another event or a bad rhythm is considered low.
But there's a catch.
Huge catch. This is the exam tripwire. If that PCI wasn't elective, if it happened because they came in with an acute coronary syndrome,
Right, an emergency.
then you default back to the 4-week rule, or potentially even longer, depending on how much heart muscle was damaged. That quick 1-week return only applies if it was truly uncomplicated and elective.
Okay, crucial distinction. What about pacemaker implantation?
Pacemaker insertion. Group 1 drivers stop driving for 1 week and must notify the DVLA about the device.
Notify.
Group 2 drivers, it's 6 weeks off driving and again must notify. That gives time for the leads to bed in properly and make sure everything's working without symptoms.
Let's try and nail down this tricky area around arrhythmias and ablations. The difference between time off driving versus having to notify the DVLA.
Yeah, this is a great example of needing absolute precision. So if the arrhythmia itself caused or is likely to cause incapacity, like syncope, then Group 1 drivers must stop driving for at least 4 weeks and they must notify the DVLA. The condition itself is the risk.
Right. But what about procedures done to prevent that, like ablation?
Exactly. The DVLA guidance distinguishes here. For a VT ablation ventricular tachycardia, they must not drive for 4 weeks afterwards, but they do not need to notify the DVLA.
Ah, interesting. No notification for VT ablation.
Correct. And for other, less risky ablations, like for atrial flutter, the driving restriction is only 2 days off. And again, no need to notify the DVLA. The key principle seems to be whether the underlying condition itself carried that risk of sudden incapacitation requiring notification.
Okay, that distinction between time off and notification is really important. Now, beyond driving, fitness to fly comes up a lot, especially post-procedure time limits. What are the key ones?
These are usually shorter and based on things like cabin pressure effects, risk of trapped gas expanding, simple things like a colonoscopy or a laparoscopy, usually just 24 hours before flying.
24 hours, okay.
Angioplasty, a PCI need 3 days.
3 days.
An uncomplicated MI, you're looking at 7 to 10 days usually, but a complicated MI, much longer, maybe 4 to 6 weeks.
Big difference.
Yeah. Even things like a pneumothorax treated with a chest drain, you'd need a check x-ray showing it's fully resolved, often wait 1 to 2 weeks, just to be safe from air expanding at altitude.
And are there absolute no-fly situations based on physiology?
Definitely. Pregnancy is a common one. Cannot fly after 32 weeks with twins or after 36 weeks with a single pregnancy.
32 twins, 36 single. Got it.
Other absolute contraindications include uncontrolled high blood pressure, uncontrolled AFib, recent treatment for a perforated eardrum like a myringoplasty because of the pressure changes,
Blood pressure.
and significant anemia, specifically HB less than 7.5. The risk there is tissue hypoxia when the oxygen levels drop in the cabin.
It really drives home how much of GP work involves these administrative safety checks. Let's just quickly run through those key forms again.
Okay, the Fit Note, the Med 3, issued by GPs, also other allied health professionals now, covers not fit for work or may be fit for work with adjustments. Remember, the patient self-certifies for the first 7 calendar days.
For 7 days self-cert. Okay, then the more serious forms. SR1.
SR1, yes, replace the old DS-1500. This is the one you use when, as a clinician, you wouldn't be surprised if the patient were to die within the next 12 months. It fast-tracks access to certain benefits, needs careful clinical judgment and communication.
And for expecting mothers.
The MAT-B1 form, usually issued around 20 weeks gestation, needed for claiming maternity pay.
Right. Now, the one that always causes headaches, the FP92A form, the list of medical conditions that grant free prescriptions. It's notoriously specific.
It is the ultimate administrative tripwire, isn't it? Trying to memorize the whole list is, well, probably impossible. But we need to know the key ones and the exceptions.
Okay, hit us with the main ones.
Diabetes is on there, but critical exception not if it's managed by diet alone.
Ah, not diet only.
Correct. Myasthenia gravis. Ongoing thyroxine treatment because stopping it is dangerous.
Okay.
Hydrocortisone or fludrocortisone for Addison's disease. Epilepsy. Having a permanent fistula requiring dressing. Cancer.
Cancer, right.
And desmopressin. But here's another specific point. Only for diabetes insipidus, not if it's being used for bedwetting or nocturia.
Only for DI. Wow, that's specific. Is there a sort of underlying logic to this list?
I think if you try to connect it to a bigger picture, many of these conditions, like needing thyroxine or treatment for Addison's, they require continuous essential medication just to maintain health or life. So it seems like a mechanism to make sure cost isn't a barrier to taking life-sustaining treatment.
That makes sense. Okay, that's a solid foundation on the rules and regs. We've seen how much relies on these hard numbers, often derived from risk data. But where does that risk data actually come from? Let's pivot now to the evidence itself, the stats that underpin all this.
Right. Understanding the hierarchy of evidence is just fundamental for evidence-based medicine. You absolutely have to have this ranking clear in your head for exams.
Level 1 is the top. What sits at the peak?
The absolute gold standard, level 1, is the systematic review, and even better, a meta-analysis of multiple high-quality studies synthesizing the evidence.
Okay, then below that.
Level 2 is your individual randomized controlled trials, RCTs. Level 3, you've got cohort studies. Level 4 is case control studies. And down at level 5, you have things like case reports or case series. Knowing this order helps you judge the strength of the evidence behind, say, those DVLA rules we just talked about.
And when we look at trials, RCTs specifically, they don't always aim to prove something is better. Sometimes they just want to show it's the same.
Exactly. We need to distinguish the trial objective. A superiority trial asks, is this new treatment actually better than the current standard or placebo?
Okay.
An equivalence trial asks a different question. Does this new treatment have a similar effect to the standard one? Usually they define a range of acceptable difference, that sort of plus or minus delta. If a new drug is, say, much better tolerated or cheaper, proving its equivalent in effect means it can be adopted.
Right. Now, the errors. Type 1 and type 2. Always confused. Let's start with type 1, the false positive.
Type 1 error, alpha error. This is when you conclude there's a difference between the groups in your study when, in reality, no true difference exists in the population. You've rejected the null hypothesis when it was actually true.
And what determines the risk of this error?
It's set by the significance level you choose beforehand, the p-value. Usually p 0.05. That means you accept a 5% chance of making a type 1 error. Crucially, the sample size of the study doesn't affect the type 1 error rate itself.
Okay, so type 2 error is the opposite, the false negative.
Exactly. Type 2 error, beta error. This is when you fail to detect a difference between the groups when a true difference does actually exist. You accept the null hypothesis when it's false. You missed a real effect.
And this is often the problem with small studies.
Precisely. Small sample size is the main culprit for type 2 errors. The larger your sample size, the more statistical power you have, and therefore the lower your chance of making a type 2 error.
So, if the type 1 error risk is fixed by the p-value, how can you, as a learner reading a paper, spot if a trial might have missed a real effect, made a type 2 error, even if they report no significant difference.
You look beyond the p-value, you look at the confidence intervals around the result.
Okay.
If the study says no statistically significant difference, but the confidence interval is really wide, maybe it stretches from showing considerable harm all the way to showing considerable benefit.
Right, includes everything.
Exactly. That tells you the study lacked precision. It didn't have enough power, probably due to too small a sample size, to definitively rule out a clinically meaningful effect. That wide confidence interval around a non-significant result is the classic sign of an underpowered study.
That's a great practical tip, which brings us nicely to power itself. How is it defined statistically?
Power is the probability of correctly rejecting the null hypothesis when it is indeed false. Basically, it's the probability of finding a statistically significant result if a real effect truly exists.
And its relationship to type 2 error.
They're inversely related. Power is calculated as 1 minus the type 2 error rate, 1 TS. So if your type 2 error risk is 20% or 0.2, your power is 80% or 0.8.
And the main way to increase power is?
Increase the sample size. More people in the study give you a better chance of detecting a true difference if one exists.
Okay, these concepts are the building blocks for understanding screening tests. Let's quickly recap the 2x2 table idea and define those 4 key metrics: sensitivity, specificity, PPV, and NPV.
Right, the 2x2 table. You've got disease present absent across the top and test positive negative down the side. This gives you true positives, A, false positives, B, false negatives, C, and true negatives, D.
Okay, so sensitivity.
Sensitivity is the proportion of people with the disease who test positive. It's calculated as true positives divided by everyone with the disease, A plus C. It tells you how well the test picks up the disease when it's there. In note, high sensitivity, negative result rules OUT.
And specificity.
Specificity is the proportion of people without the disease who test negative, calculated as true negatives divided by everyone without the disease, DD plus B. It tells you how well the test correctly identifies those who don't have the disease. SPPN, high specificity, positive result rules, IN.
Okay, SNOUT, SPPN. Useful mnemonics. Now, PPV and NPV, these often feel more directly useful day-to-day.
They really are, because they factor in the result you actually have in front of you. The positive predictive value, PPV, asks, if my patient tested positive, what's the probability they actually have the disease? It's true positives divided by everyone who tested positive, A plus B.
And NPV.
Negative predictive value, NPV. If my patient tested negative, what's the probability they do not have the disease? It's true negatives divided by everyone who tested negative, DD plus C.
Now, the crucial point here, especially for primary care, is how prevalence affects these.
Yeah.
PPV especially.
Massively. This is so important. Sensitivity and specificity are characteristics of the test itself. They don't change much with prevalence. But PPV and NPV depend hugely on how common the disease is in the population being tested.
Give us an example.
Okay, take a test with, say, 95% sensitivity and 95% specificity. Pretty good test, right?
That's good.
If you use that test in a specialist hospital clinic where maybe 50% of the people actually have the disease, high prevalence, the PPV will be really high, maybe around 95%. A positive test is very likely true.
Okay.
But now, take that exact same test and use it for screening in the general population, where the disease prevalence might be only 1%. The PPV plummets. It might be less than 20%.
Wow, only 20%.
Yeah. Most of your positive results will actually be false positives in that low prevalence setting. That's why PPV is often the number we really care about in GPS. What does this positive result actually mean for this patient in this population?
That really clarifies why understanding prevalence is critical when interpreting results. Okay, let's apply this to the real-world UK public health screening programs. Ages and intervals are pure recall high-yield facts. Cervical screening first, it's changing soon.
Yes, cervical screening, currently for ages 25 to 64. The big change coming planned for after July 2025 is about the interval for younger people. Those aged 25 to 49 who test HPV negative.
HPV negative.
Will move to 5-yearly screening. Currently, it's 3-yearly for that age group. The evidence shows a negative HPV test gives very strong reassurance for a longer period.
Okay, 5-yearly for HPV negative under 50s post-July 2025. Now, the complex bit. The pathway, if the sample comes back HPV positive, this is a multi-step algorithm.
It is. Let's walk through it. So lab tests for high-risk HPV first. If that's positive, then they look at the cytology, the cells.
Okay. Scenario 1, HPV positive and the cytology shows abnormal cells.
That's straightforward. Refer straight for colposcopy.
Right. Scenario 2, HPV positive, but the cytology is negative. Cells look normal, but the virus is there.
This triggers the monitoring pathway. The advice is to repeat the HPV test in 12 months. That's test number 2. You're waiting to see if their immune system clears the virus.
Okay, repeat in 12 months. What if 12 months later, they are still HPV positive and still cytology negative?
Then you repeat the HPV test again in another 12 months. So that's now test number 3, 2 years after the initial positive result.
Okay, a third test after 2 years. And if that test is still HPV positive, even if cytology is still negative,
then they get referred for colposcopy. The guideline says refer without cytology at this point. The persistent presence of high-risk HPV over 3 consecutive tests is deemed sufficient risk to warrant colposcopy, even if no cell changes are visible yet.
Got it. Persistent HPV for 3 years triggers colposcopy. That's clear.
Okay.
Breast screening, simpler ages.
Much simpler. Offered every 3 years for women aged between 50 and 71. Some areas are trialing expansion, but 50-71 is the standard recall interval.
50 to 71 every 3 years. Bowel screening, that's expanding too.
Yes, the bowel cancer screening program using the fecal immunochemical test, FIT, is gradually expanding to cover everyone aged 50 to 74. It's offered every 2 years.
50 to 74 every 2 years. What about over 75s?
They're not automatically recalled, but they can still request a screening kit every 2 years by calling the free helpline. Important to let them know that.
Good point. And finally, AAA screening.
Abdominal aortic aneurysm screening. This is a one-off ultrasound scan offered to all men in England during the year they turn 65.
Men only, at 65, one time. Okay.
Moving into pediatrics now. For exams, recognizing patterns is key, especially for genetic syndromes. We often rely on specific physical signs, like musculoskeletal or cardiac findings, to differentiate them quickly.
Okay, let's take a classic pairing. Rocker bottom feet. Which 2 trisomies present with that?
Rocker bottom feet, that distinctive convex sole, is a feature of both Edwards syndrome, which is trisomy 18,
Trisomy 18.
and Patau syndrome, trisomy 13.
Okay, so how do you tell Patau 13 from Edwards 18 if they both have rocker bottom feet?
Patau, trisomy 13, often has associated midline defects. Think polydactyly, extra fingers or toes, and cleft lip or palate. Edwards, trisomy 18, classically has overlapping fingers, clenched fists, and often severe heart defects, too, alongside profound developmental delay.
Midline defects point towards Patau.
Got it.
Now, another pair that can look similar superficially, Turner syndrome and Noonan syndrome. Both can have a webbed neck, short stature, pectus excavatum. How do we use the heart to distinguish them?
It often comes down to the outflow tracts. Turner syndrome, which is 45,000 X0 type, is associated with left-sided heart issues, typically a bicuspid aortic valve or coarctation of the aorta.
Left side for Turner. And Noonan.
Noonan syndrome, which is an autosomal dominant condition, classically affects the right side. The typical lesion is pulmonary stenosis. You'd hear that as an ejection systolic murmur, or ESM, best heard at the second left intercostal space.
Right side pulmonary stenosis for Noonan. And while we're on cardiac murmurs in syndromes, Williams syndrome.
Ah, yes, Williams. Think supravalvular aortic stenosis. That's also an ESM, but usually loudest at the right upper sternal border. Distinctive facial features, too, the elfin facies.
Okay, good differentiators. What about Fragile X versus Prader-Willi? Key features.
Fragile X syndrome, remember, it's the most common inherited cause of intellectual disability. Key features are often a long face, large ears, prominent jaw, and then, especially after puberty in boys, macroorchidism, which means large tests.
Large tests post-puberty in Fragile X and Prader-Willi.
Prader-Willi is quite different. Starts with severe hypotonia, floppiness, and feeding difficulties in infancy. Then, this switches dramatically to hyperphagia, uncontrollable eating leading to obesity. Also associated with hypogonadism and developmental delay.
Okay, distinctive patterns. Now, shifting to acute pediatrics. Asthma severity, this relies heavily on objective numbers, especially for the life-threatening category. What are those crucial cutoffs?
Absolutely critical for safe triage. The definition of life-threatening asthma includes in SpO2 less than 92%.
Less than 92% oxygen sats.
Or a peak expiratory flow rate, PEFR. That's less than 33% of their best or predicted value.
PEFR, less than 33%.
Right. And remember, clinical signs like a silent chest, cyanosis, or obvious exhaustion trump the numbers. Those automatically mean life-threatening.
And acute severe asthma, where does that sit?
Acute severe is the category below life-threatening. defined by a PEFR between 33% and 50% of best or predicted, plus other signs like inability to complete sentences, high respiratory rate, high heart rate.
33 to 50% PEFR for severe. Okay, let's take croup. Child comes in, classic barking cough, stridor. Looks okay otherwise. What's the first-line treatment and the exact dose?
First line for mild to moderate croup is a single dose of oral dexamethasone. The dose is 0.15 milligram per kilogram.
0.15 milli kilogram oral dex.
That's the standard. Works well to reduce that laryngeal inflammation.
What if they're too distressed or vomiting, can't take it orally?
Good question. There are specific alternatives. You can use inhaled budesonide, usually given as a single 2 milligram nebulized dose.
2 milligram nebbed budesonide.
Or you can use intramuscular dexamethasone, but notice the dose change for I. It's a higher dose. 0.6 milligram per kilogram, single dose.
0.6 milli was IM. 4 times the oral dose. Important distinction.
Very important safety point, yeah.
Okay. Bronchiolitis. Usually RSV, usually supportive care, but there are respiratory rate red flags for escalation.
Absolutely. You're watching their work of breathing and counting that respiratory rate carefully. If the RR goes above 60 breaths per minute,
over 60,
you need to be discussing with pediatrics. There might be issues with feeding, tiring, needing admission. If the RR goes above 70 breaths per minute,
over 70,
that child is working incredibly hard just to breathe. They're at high risk of tiring out completely. The advice is often to call an ambulance at that point, as it suggests impending respiratory failure.
RR over 70 equals ambulance. Clear threshold. Okay, the limping child. A common presentation, wide differential. How do we approach it, thinking about age?
Age is really helpful here. For the very young child, say under 3 years old, if they have a limp and are febrile or unwell.
Fever plus limp in a toddler.
The diagnosis you absolutely cannot miss is septic arthritis. Needs urgent hospital admission and assessment.
Okay. What about slightly older primary school age, say 4 to 8 years old?
That's the peak age for Perthes disease, a vascular necrosis of the femoral head. The key sign is often limited hip movement in all directions, especially internal rotation and abduction, often insidious onset.
Perthes, 4 and 8 years, limited movement.
And the teenagers, especially overweight teens.
Then you have to think about slipped upper femoral epicysis, or S-youth, sometimes called SCFE. Yeah. Typically occurs during the adolescent growth spurt, often in obese children aged maybe 10 to 16. They present with hip, thigh, or sometimes knee pain and a painful limp, often with the leg externally rotated. Needs urgent ortho referral.
Cephas CE in obese teens. Got it. Okay, let's switch to developmental milestones. Gross motor first. What are the absolute red flags for referral? Key gross motor ones to know. Should have no significant head lag when pulled to sit by 3 months. Should be sitting without support somewhere between 7 and 8 months typically. Walking most start between 13 and 15 months. The definite referral point is if they are not walking independently by 18 months.
Refer if not walking by 18 months. What about fine motor and social? Any hard deadlines there?
For fine motor, the pincer grip picking up small things between thumb and forefinger should develop between 9
and so after 12 months needs referral. Is there a specific neurological red flag related to hand use?
Yes, a really important one. If you notice a strong, consistent hand preference before the age of 12 months.
Early hand preference.
That needs urgent referral. Normally, babies use both hands fairly equally early on. Early preference suggests the other hand might be weak or abnormal, perhaps due to something like hemiplegic cerebral palsy. It's a subtle but crucial sign.
Wow, okay. Early hand preference equals urgent referral.
Good.
And social milestones.
The social smile should appear by around 6 weeks. Engaging in interactive games like peekaboo usually starts around 9 months.
Okay, final bit in PAIDS. Vaccines. Specifically, the rules around live vaccines and immunosuppression, which are the main live ones we use.
The common live attenuated vaccines in the UK schedule are MMR, measles, mumps, rubella, and the intranasal fluenza tetra vaccine, the nasal flu spray for children.
MMR and nasal flu.
Key rules.
Rule 1. Generally not given routinely during pregnancy. It's a theoretical risk, but avoided. Rule 2. If you're giving 2 different live vaccines and they're not given on the exact same day,
not simultaneously,
then you must leave a gap of at least 4 weeks between them. This allows the immune system time to respond properly to the first one before getting the second.
4-week gap if not simultaneous.
Okay.
And the rules for giving live vaccines to someone on immunosuppressants, these have specific time frames.
Yes, very specific delays are needed after stopping immunosuppression. If someone has been on high-dose systemic corticosteroids, think prednisolone 40 milligrams daily for more than a week, or lower doses for longer periods. high-dose steroids.
You must wait at least 3 months after stopping the steroids before giving a live vaccine.
3 months post-steroids.
Right. And for other more potent immunosuppressive drugs, things like biologics, anti-TNFs, etc., methotrexate, azathioprine, or after generalized radiotherapy.
Stronger drugs or radiotherapy.
The waiting period is longer. You need to wait at least 6 months after stopping those treatments before giving a live vaccine. Allows more time for immune reconstitution.
6 months post-biologics chemo. Got it. Those timings are crucial.
Dermatology, next. And the protocols here are really defined by specific timings and combinations, especially with acne and psoriasis. It's all about balancing efficacy with safety, managing antibiotic resistance and steroid side effects.
Right. Let's start with acne. First-line treatment usually involves a 12-week course, and combination topicals are preferred.
That's the standard approach. We aim for a topical combination from the start if possible. Good examples are fixed combos like adapalene, which is a retinoid mixed with benzoyl peroxide, or maybe clindamycin with benzoyl peroxide. You give these a good 12-week trial to see if they work.
And if it's more moderate to severe acne.
Then we usually add in an oral antibiotic alongside the topical treatment. Standard choices are things like limecycline or doxycycline. So it's combined therapy, oral plus topical.
Now, the really important rule here, especially for antibiotic stewardship and frankly for exam safety, the time limit on using antibiotics in acne.
This is a core safety and stewardship point. The guidance is clear. Oral or topical antibiotics should normally only be continued for a maximum of 6 months.
6 months max for antibiotics.
In most cases, yes. There might be exceptional circumstances, but the plan should always be to review them regularly, typically every 3 months, and aim to stop the antibiotic once the acne is under control, continuing with topical treatment alone for maintenance. We really want to limit that exposure to minimize resistance.
Makes sense. So what triggers a referral to dermatology for acne? When have we exhausted primary care options?
Referral is definitely needed if the acne is moderate to severe and it's just not responding adequately despite a decent trial of treatment that included an oral antibiotic.
Failed oral antibiotics in moderate severe acne.
Okay. Also, if the acne is maybe milder, say mild to moderate, but it has failed to respond properly to 2 different 12-week courses of appropriate first-line topical therapy.
Failed 2 different topical courses for mild moderates.
Got it. And what about isotretinoin? GPs are often involved in monitoring. Key points.
Yes, often shared care. The crucial monitoring points. Patients must be reviewed face-to-face about 1 month after starting isotretinoin. And then at every single follow-up appointment, you need to actively ask about and document mental health side effects, especially mood changes, depression, suicidal thoughts, and also sexual dysfunction. These are known, serious potential side effects. Essential checks every time for isotretinoin. Okay, shifting gears to psoriasis. Plaque psoriasis management often starts with a potent topical steroid plus a vitamin D analog. What's the key rule governing the steroid use here?
For plaque psoriasis on the body or limbs, yes, a potent topical steroid combined with a vitamin D preparation, like calcipotriol, is standard. They're often applied once daily, maybe steroid in the morning, Vit D at night, or using a combined product. The absolute rule is the steroid course must not exceed 8 weeks duration at any single site.
8 weeks maximum for potent steroid on one patch of skin. Why such a strict limit?
It's all about safety. Using potent steroids for too long causes problems. Tachyphylaxis, where it stops working as well.
Right.
But more seriously, skin thinning, atrophy, stretch marks, ceridere, visible blood vessels, telangiectasias, and even potentially suppressing the body's own steroid production, the HPA axis, if large areas are treated.
So after 8 weeks, what happens? Just stop.
You must have a break. After the 8-week course, there needs to be a mandatory 4-week treatment-free interval for that potent steroid on that specific site before you can consider restarting it if needed. The vitamin D analog, though, can often be continued during that steroid break.
8 weeks on, 4 weeks off for potent steroids. Now, the critical contrast. How do we manage psoriasis in sensitive areas? Face, flexures, genitals. This is a classic trap.
Absolutely critical difference. You should not prescribe potent or very potent topical corticosteroids for these areas. The skin is much thinner, absorbs more steroid, much higher risk of side effects.
So what can you use?
Only mild or moderately potent topical corticosteroids should be used on the face, flexures, or genitals. And even then, the duration should be much shorter, limited to a maximum of 2 weeks per course.
2 weeks max for mild, moderate, unsensitive skin.
Yes. And they still need that 4-week treatment break between courses, just like the potent ones elsewhere. It's about minimizing total exposure.
Okay, scalp psoriasis.
Yeah.
often need something to get through the scale first.
Exactly. For the scalp, you typically use a potent topical steroid or a vitamin D preparation, but often in a formulation like a lotion, gel, or foam that can penetrate better. If there's thick scale, you absolutely need to treat that first. Use something keratolytic like salicylic acid preparations, or even simple emollients like coconut oil or olive oil, left on overnight perhaps, to soften and lift the scale. Otherwise, the steroid just sits on top and doesn't work.
Treat the scale first. The 8-week potent steroid limit still applies to the scalp.
Yes, the 8-week limit per site still applies to potent steroids used on the scalp.
Okay, let's quickly cover rosacea management and contrast it with perioral dermatitis, which has that specific steroid issue.
Rosacea treatment is layered based on features. If the main issue is just persistent redness, the erythema,
Just the flushing.
then topical bromonidine gel can help. It's an alpha agonist, constricts blood vessels, gives temporary relief. Doesn't treat the underlying condition, though.
Okay. What about the spots, the papules, and pustules?
For papules and pustules, first line is usually topical ivermectin cream, used for maybe 8-12 weeks. Alternatives include topical metronidazole or azelaic acid.
And if it's more severe?
Moderate to severe papulopustular rosacea, you typically combine the topical ivermectin with a low-dose oral antibiotic, specifically doxycycline 40 milligram modified release, again for about 8-12 weeks.
Okay, layered approach. Now the crucial exception, perioral or periorificial dermatitis. Looks a bit like rosacea sometimes around the mouth or nose. Steroids.
Absolutely not. This is the key learning point. Perioral dermatitis is often caused or worsened by topical steroids. So steroids are contraindicated.
No steroids for perioral dermatitis. How do you treat it then?
Management is usually with oral antibiotics, often a tetracycline like doxycycline or limecycline at a low dose for several weeks, sometimes alongside stopping all facial creams except a simple emollient.
Right. And one last quick one. Molluscum contagiosum. Usually self-limiting, but when should we refer?
Referral is generally needed if the patient is known to be HIV positive, as it can be much more widespread or persistent. Also refer if the lesions are in the genital area or if there's a lesion very close to the eye or causing a red eye, conjunctivitis, as that needs an ophthalmology opinion. Okay, cardiology. Again, very protocol-driven, lots of numbers and specific steps. Hypertension management, that ACD algorithm. It can feel a bit like navigating a flow chart sometimes. We need those BP cutoffs and the steps crystal clear.
Let's start with defining stage 1 and stage 2 hypertension. What are the numbers, both clinic and home ambulatory?
Okay, stage 1 hypertension, that's a clinic BP reading of 420/90 up to 4,999 milli-BHG. Or if you're using ambulatory or home monitoring, it's an average daytime reading of 135/85 up to 400/990 to 135 milli-BHG.
The 140/90 clinic, 135/85 home for stage 1 and stage 2.
Stage 2 is higher. Clinic BP of 160/100 milli-LHG or more, but below the severe level of 195 milli-LHG or higher.
160/100 clinic, 150/75 home for stage 2. Okay.
Yeah.
Now, the treatment steps. Step 1 depends entirely on age and ethnicity, right?
Yeah. Correct. Step 1 choice. You offer A, that's an AC inhibitor or an angiotensin receptor blocker, ARB.
A for ACE-IRB.
If the patient is under 55 years old, or if they have type 2 diabetes, regardless of their age.
Under 55 or our T2DM gets A, who gets C.
C, a calcium channel blocker, CCD, is for patients aged 55 or older, or the patient is of Black, African, or African Caribbean family origin, irrespective of age, unless they also have type 2 diabetes, in which case A takes priority.
55 plus O or Black ethnicity gets C, unless T2DM. And remember, if A causes that cough.
Switch ACEI to ARB, but never combine an ACEI and an ARB.
Right. Step 2 then, adding a second drug.
Step 2 is the first combination. If you started with A, you add C or D, D being a thiazide-like diuretic like indapamide or chlortalidome. If you started with C, you add A. So basically A plus C or A plus D.
A plus C or A plus D. Makes sense. Step 3.
Step 3 is the triple therapy. A plus C plus D, that's your ACEI or ARB, plus a calcium channel blocker, plus a thiazide-like diuretic. At this stage, it's crucial to make sure all 3 drugs are titrated up to the maximum tolerated doses.
A plus C plus D, all optimized. Okay. Now, step 4. This is for resistant hypertension, and it needs blood tests first.
Yes, resistant hypertension is when the BP is still not controlled despite optimal doses of A plus C plus D. Before adding the 4th drug, you must check their electrolytes, specifically potassium.
Check the potassium. Why?
Because the choice of the 4th agent depends on it. If their blood potassium level is 4.5 millimol or less,
Ka 4.5.
then the preferred step 4 agent is low-dose spironolactone, an aldosterone antagonist.
Okay, and if potassium is higher than 4.5?
If K is greater than 4.5 millimol, then adding spironolactone carries too high a risk of hyperkalemia. In this case, you'd consider adding either an alpha blocker, like doxazosin, or a beta blocker instead.
So potassium dictates spironolactone versus alpha-beta blocker. Why is monitoring potassium so vital when using ACEI-ARs and spironolactone together?
Because both drug classes, the AA drugs, ACEI-ARBs, and the MRAs like spironolactone, can cause potassium levels to rise. Using them together significantly increases the risk of potentially life-threatening hyperkalemia.
So what checks are needed?
When starting or increasing the dose of an ACEI, ARB, or spironolactone, you absolutely must check urea and electrolytes, UNEs, specifically potassium and creatinine for kidney function at baseline, then usually, again, within 1-2 weeks of the change, and then monitor periodically thereafter depending on stability and renal function. It's a critical safety net.
Baseline 1-2 weeks, then periodically.
Got it.
And the vital pregnancy warning for ACE inhibitors and ARBs.
Cannot stress this enough. ACE inhibitors and ARBs are teratogenic. They must not be used in women who are pregnant, planning pregnancy, or breastfeeding, need alternative agents like labetalol or nifedipine.
Essential point. Okay, let's move to heart failure. Management here also starts with a number, the NT-proBNP level dictating referral urgency.
Yes, NT-proBNP is the key initial biomarker. If the level comes back very high, specifically greater than 2,000 NGL,
I'm over 2,000.
that patient is considered high risk. They need urgent referral for specialist assessment and an echocardiogram within 2 weeks. Getting that diagnosis and starting treatment quickly for HFrEF heart failure with reduced ejection fraction makes a big difference to outcomes.
Urgently refer if over 2,000. What if it's raised but not that high, say 400 to 2,000?
If the NT-proBNP is in that intermediate range, 400 to 2,000 NGL, heart failure is still suspected. They still need referral for an echo and specialist assessment, but the time frame is slightly less urgent, typically within 6 weeks.
400 to 2,000 refer within 6 weeks.
Yeah.
And below 400?
Below 400 NGL makes significant heart failure much less likely. Look for other causes for their symptoms.
Okay. Now, for confirmed heart failure with reduced ejection fraction, HFrEF, there's a specific sequence of adding drugs.
Yes, for HFrEF, the foundation of treatment involves starting both an ACE inhibitor, or ARB, and a beta blocker proven to benefit in heart failure, like bisoprolol, carvedilol, nebivolol. Usually start one, then add the other, titrating both up slowly to the maximum tolerated dose.
ACI and beta blocker first. What's next if they remain symptomatic?
If they still have symptoms despite optimal doses of ACI and beta blocker, the next step is to add an MRA mineralocorticoid receptor antagonist like spironolactone or eplerenone, again, vital to monitor potassium and renal function when adding this.
ACI plus beta blocker plus MRA. Okay. What about the newer or add-on therapies for more advanced HFrEF?
If symptoms persist on those 3, there are further options. We can consider switching the ACE inhibitor, or ARB, to an AR-on-angiotensin receptor neprilysin inhibitor, which is a Cubitril valsartan. But this is usually only recommended if their ejection fraction is still less than 35%.
Switch ACI to ARNI if EF 35%. What else?
SGLT2 inhibitors like dapagliflozin or empagliflozin are now also considered standard care to add on, regardless of diabetes status, as they've shown significant benefit.
Add SGLT2I. Any role for ivabradine?
Ivabradine has a very specific niche. It can be considered if the patient is in sinus rhythm and their heart rate remains above 75 beats per minute despite maximal beta blockade, and their EF is less than 35%. It works by selectively slowing the heart rate.
Sinus rhythm, HR 75, EF 35 for ivabradine. Okay. Now, critically, how does this differ for HFpEF heart failure with preserved ejection fraction?
Big difference. For HFpEF, the evidence for specific drug treatments improving prognosis is much weaker. Management focuses mainly on treating the underlying causes and comorbidities like controlling hypertension, managing AF, treating ischemia, managing fluid overload with diuretics. Importantly, those cornerstone drugs for HFrEF, ACE inhibitors, beta blockers, MRAs are not routinely recommended specifically to improve outcomes in isolated HFpEF.
Key distinction. HFpEF management is about comorbidities, not the same prognostic drugs as HFrEF.
Right.
Let's quickly touch on a couple of drug toxicity interaction points. Lithium toxicity, early versus late signs.
Lithium has a narrow therapeutic index, so toxicity is a real risk. Early, milder signs might be a fine tremor, dry mouth, increased thirst and urination. polydipsia, polyuria, maybe some nausea.
Okay, those are the warnings. What are the later, more serious signs?
Later signs indicate more severe toxicity and are dangerous. Look for coarse tremor, ataxia, unsteadiness, slurred speech, confusion, muscle twitching, eventually leading to seizures, coma. Needs urgent assessment.
Right. And the classic CYP450 enzyme inducers and inhibitors. Always useful to have a few examples in mind for interactions.
Definitely. Inducers speed up the metabolism of other drugs, potentially making them less effective. The mnemonic CRAP GPs helps. Carbamazepine, rifampicin, alcohol, chronic use, phenytoin, grizifulvin, phenobarbital, sulfonylureas.
CRAP TPs for inducers.
Find that.
And inhibitors. They slow metabolism, risk of toxicity.
Yes, inhibitors increase levels of other drugs. The mnemonic sickfaces.com is popular. Sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, alcohol, acute binge drinking, grapefruit juice, chloramphenicol, erythromycin and other macrolides, sulfonamides, ciprofloxacin and other quinolones, omeprazole and other PPIs, metronidazole.
Sickfaces.com for inhibitors. Useful lists. Finally, quick-fire opioid conversions. These rely on specific ratios.
Gotta know these. Breakthrough dose of immediate-release morphine is always 1/16th of the total 24-hour morphine dose.
16th for breakthrough. Morphine to oxycodone.
Oral morphine to oral oxycodone. Divide the morphine dose by 1.5. Oxycodone is roughly 1.5 times stronger.
Morphine 1.5 equals oxycodone. Codeine to morphine.
Oral codeine to oral morphine. Divide the codeine dose by 10. Codeine is much weaker.
Codeine 10, morphine and morphine to a buprenorphine patch. Sounds trickier.
It is. The approximate conversion is divide the 24-hour oral morphine dose by 2.4 to get the rough equivalent buprenorphine patch strength in micrograms hour. For example, 60 milligram morphine day, a 25 mil Phe zero patch. But always check specific conversion charts.
Morphine 2.4, buprenorphine patch strength. Okay, those are really handy ratios.
Right, last section. We're focusing here on some specific doses, cutoffs, and distinctions in women's health and endocrinology, places where, again, pregnancy often dictates different choices.
Let's kick off with STI management, specifically differentiating bacterial vaginosis, BV, from trichomoniasis, and the really crucial metronidazole dosing difference in pregnancy.
Okay, so BV typically presents with that thin, grayish-white vaginal discharge, often with a characteristic fishy odor, especially after intercourse, caused by an overgrowth of anaerobic bacteria.
Thin, gray, fishy for BV. And trichomoniasis.
Trichomoniasis is a protozoal infection, often sexually transmitted. The classic description is a frothy, yellow-green, often copious discharge, sometimes with vulval itching or soreness, and maybe dysuria. Can also see strawberry cervix on examination.
Frothy, yellow-green for trichomonas. Both treated with metronidazole.
Yes, metronidazole is the mainstay for both. For BV, standard treatment is often oral metronidazole 400 milligrams twice daily for 5 to 7 days. Similar regimens are used for trichomoniasis.
Now, the absolutely critical point for exams and safety. The high-dose single regimen versus the standard course, especially in pregnancy.
This is vital. For non-pregnant patients, a single high oral dose of metronidazole, 2 grams, 2G, is sometimes used as an alternative regimen for convenience for both BV and trichomonas.
2G single dose. But not in pregnancy.
Absolutely not. That high-dose 2G single oral dose is contraindicated during pregnancy and also during breastfeeding. The concern is the high peak level and potential exposure to the fetus or infant.
Contraindicated. So what do you use in pregnancy or breastfeeding?
You must use the standard lower-dose, longer course regimen. That's typically the oral metronidazole 400 milligrams twice a day for 5 to 7 days. This gives lower, more sustained levels, which is considered safer.
400 milligram BD for 5-7 days is the safe choice in pregnancy breastfeeding. Got it. What about gonorrhea treatment quickly?
Gonorrhea treatment depends on sensitivities now. If sensitivities are unknown, the standard is single-dose intramuscular ceftriaxone 1 gram. If it's known to be susceptible to ciprofloxacin, then oral ciprofloxacin of 500 milligrams single dose is an option. Always check local guidelines as resistance patterns change.
Okay. Pregnancy also brings specific rashes. We need to be able to distinguish the common ones, often based on where they start. PP versus pemphigoid gestationis.
Right. Polymorphic eruption of pregnancy, PEP, sometimes called PUPPP. This is common usually in the 3rd trimester, intensely itchy, pruritic, and typically starts within the abdominal stretch marks, the stria, often spares the umbilicus.
Starts in striae for PP. How's it managed?
Management is usually symptomatic emollients, maybe mild to moderate potency topical steroids for the itch, usually resolves after delivery.
Okay. And pemphigoid gestationis. Sounds more serious.
It is. This is an autoimmune blistering disease, rarer than PB. The rash classically starts around the umbilicus, often with urticarial plaques that then develop blisters. It can be very itchy and distressing.
Starts around umbilicus for pemphigoid. Management.
Because it's autoimmune and blistering, it often requires more potent treatment. Management is typically with potent topical steroids or often systemic treatment with oral corticosteroids. Needs specialist input.
Oral steroids often needed for pemphigoid. Okay. What about exposure to chickenpox, VZV, in pregnancy if the woman isn't immune?
Varicella-zoster virus exposure in a non-immune pregnant woman is serious. If she's confirmed VZV, IgM, and IgG negative, so non-immune, and she's more than 20 weeks pregnant.
Over 20 weeks, non-immune exposure.
She should be offered treatment to reduce the severity of illness in her, which indirectly might protect the baby. Options are antiviral therapy with acyclovir or administration of varicella-zoster immunoglobulin, VZIG, if she presents within 10 days of the exposure.
Acyclovir, or VZIG, if 20 weeks and presents within 10 days.
Okay.
Now, blood pressure in pregnancy. We need to clearly define gestational hypertension versus preeclampsia.
Both involve a new onset of hypertension, defined as BP greater than 149 milli-90 Hg, occurring after 20 weeks of gestation.
BP 140/90 after 20 weeks for both. What makes it preeclampsia?
Preeclampsia requires that new hypertension plus evidence of endothelial dysfunction, which usually manifests as significant proteinuria. Or alternatively, preeclampsia can be diagnosed with the new hypertension plus other maternal organ dysfunction like renal insufficiency, liver involvement, neurological features, hematological complications, or evidence of fetal growth restriction even without proteinuria. It's a multi-system disorder.
Hypertension plus proteinuria or other organ dysfunction, FGR.
Got it.
And who should be offered low-dose aspirin in pregnancy to reduce the risk of developing preeclampsia?
A low-dose aspirin, usually 75-150 milligrams daily, is recommended from 12 weeks gestation until birth for women considered at high risk of preeclampsia.
Who counts as high risk?
High-risk factors include having pre-existing conditions like chronic hypertension, type 1 or type 2 diabetes mellitus, chronic kidney disease, CKD, or autoimmune diseases like SLE or antiphospholipid syndrome. Also having had preeclampsia in a previous pregnancy.
Previous preeclampsia, HTN, DM, CKD, autoimmune. Any others?
Yes. Moderate risk factors where you might offer aspirin if 2 or more are present include first pregnancy, age 40 or older, BMI of 35 or more, multiple pregnancy, or a long pregnancy interval.
Okay, good list. Finally, a few quick endocrine points. Subclinical hypothyroidism. When do we treat based on the TSH level?
Subclinical hypothyroidism means a raised TSH level but a normal free T4 level. The key numerical cutoff for considering treatment is TSH greater than 10 MIUL.
TSH over 10.
Yes. If TSH is consistently over 10, treatment with levothyroxine is usually recommended, even if the patient is asymptomatic, especially if they're younger, say under 70. The main reason is to prevent progression to overt hypothyroidism and potential adverse cardiovascular effects.
Treat if TSH 10. If 70-0. What if the TSH is just mildly raised, say, between 5 and 10, and they feel fine?
If the TSH is in that gray area, between the upper limit of normal, around 4 to 5 and 10, and the patient is asymptomatic, the usual approach is observation. Repeat the thyroid function tests, TFTs, in maybe 3 to 6 months. Many will revert to normal. You'd be more likely to treat in this range if they were symptomatic, trying to conceive, pregnant, or had positive thyroid antibodies.
Observe and repeat if TSH 510 and asymptomatic.
Okay.
Primary hyperparathyroidism, PHPT. What are the defining blood tests?
PHPT is biochemically defined by hypercalcemia, a raised adjusted calcium level occurring together with an inappropriately normal or raised parathyroid hormone PTH level. Normally, high calcium should suppress PTH, so if PTH is normal or high in the face of high calcium, it suggests the parathyroid glands are overactive and driving the problem.
High calcium plus normal high PTH equals PHPT. And the classic symptoms.
The old mnemonic still holds. Bones, stones, abdominal grounds, and psychic moans. So bone pain, fractures, osteoporosis, kidney stones, abdominal pain, constipation, pancreatitis, and fatigue, depression, confusion.
Bones, stones, groans, moans. Got it. Lastly, bone mineral density, BMD, scores from a DEXA scan, T-score versus Z-score.
The T-score is the main one used for diagnosing osteoporosis in postmenopausal women and men over 50. It compares the patient's BMD to that of a healthy young adult, peak bone mass, usually around 30 years old, of the same sex.
T-score compares to a healthy 30-year-old. What are the cutoffs?
A T-score between MADRS 1.0 and NADRS 2.5 standard deviations, SD, below the young adult mean, is defined as osteopenia. low bone mass. A T-score of NADH 2.5 SD or lower defines osteoporosis.
T-NADH 2.5 is osteoporosis. And the Z-score, who is that used for?
The Z-score compares the patient's BMD to that of an average person of the same age and sex. It's more useful for assessing bone density in premenopausal women, men under 50, and children, where comparing to peak bone mass isn't as relevant. A very low Z-score, e.g. below NADH 2.0, might suggest a secondary cause for bone loss.
Z-score compares to same age sex. Useful for younger people or secondary causes.
Okay.
Hashtag outro.
So wrapping that up, what we've really tried to do today is take a huge volume of information, those specific numbers, time frames, steps, and distill them into actionable facts. And hopefully, by adding some of the why, the rationale behind the rules, it makes them a bit easier to recall under pressure, whether it's that 3-year persistence rule for referring HPV positive cytology, negative smears, or remembering the specific U&E checks needed when you're adding spironolactone at step 4 hypertension. Mastering these details really is core to demonstrating safe, evidence-based practice.
Absolutely. You should now have, hopefully, a much clearer, more consolidated set of protocols and benchmarks covering those key areas. The admin rules, the stats interpretation, those high-stakes pay-it scenarios, and the stepwise management in cardiology and dermatology. It really is the essential backbone for getting through those clinical knowledge exams.
And if we just connect this back to the bigger picture, really understanding these frameworks, like the 12-month seizure-free driving rule or the strict 8-week maximum for a potent steroid course on a limb, it's that understanding that allows you to act decisively, act safely when time might be critical in clinic. It helps turn that abstract textbook knowledge into a confident, immediate clinical response that always puts patient safety first.
That's perfectly put. Now, we spent quite a bit of time on those clear regulatory time cutoffs from the DVLA for flying after things like MIs or strokes.
Yeah.
1 week post-elective PCI, 4 weeks post-uncomplicated MI. They're pretty rigid.
Yeah.
Based on risk data.
Yeah.
Now think about recovery times for other common things, like major surgery. Maybe 6 to 8 weeks off driving, often advised after an open abdominal hysterectomy, or similar after complex joint surgery. These aren't usually set by law, more by clinical judgment and tissue healing times. So here's the final thought. How do you, as the clinician, balance these sorts of rigid, evidence-based regulatory benchmarks we focused on today with the individual patient sitting in front of you? They're often very strong, very understandable desire to get back to normal life, back to driving, back to work, perhaps faster than the average suggests. That challenge, applying this hard-won knowledge about rules and risks, but applying it with empathy, considering the individual context, and communicating it effectively. That's maybe the real core task of being a GP. And that's the skill we hope this deep dive helps you build for your practice.